Great, thanks and welcome to everyone to this session on what I think is the last day of the HSR conference. I'm Joe Cutzen, and we're having a 2-hour session called Health Financing Policy and Health Financing Policy and Politics, Moving Towards UHC in the New Era. I am just going to give everybody a chance to arrive while I share my screen. And good. Great, and let me. Great, so we're all here. And while giving a bit of time for new arrivals to join. Just to say, this initially had a much longer title, but thankfully we were convinced to change it. In this opening talk, I'm just going to give a brief overview of what we're going to try to address in this session. I'm calling it Pursuing UHC in a Less Naive Manner. And this is really trying to speak to the issue of going beyond the technical and really moving into some of the political dimensions that we haven't always talked enough about in the context of UHC, but I think are unavoidable. So the objectives are, is here, we really want to explore both technical and political options to move towards UHC, even when let's say the political environment or debates over core values in societies are not really conducive for this. We also want to see if there are any lessons as yet, both from the experience of COVID and the response to it, and in the nature of HSR really being about research to identify gaps and priorities for applied research. And the idea, because of the time limitations, is really to approach these issues through the lens of health financing and looking at purchasing payment systems in particular at that, but we may broaden the perspective as we go forward. This is just an overview of the session. So I am going to start, and really we're going to have, following this, 2 more introductory presentations to really set the stage, and we'll have some take your Q&A in the boxes concerned and look at those to try to get some initial discussion going after those. Then we'll have a panel, 2 sets of presentations from people working at country level. I'm not going to go through the names, they'll introduce themselves as they start. And then to have a final panel discussion around reflections on what's been said so far, and also focusing in particular on research priorities. And then we'll try to open up again. So just some background for us in this, and just to say that this will be the 5th consecutive HSR symposium in which we have done a satellite session. All the others have been full-day events. That's not really a good idea in the virtual world, as we've come to learn. And there's a bit of a trend in this going forward, and looking really at technical issues and universal coverage, and looking at a whole range of issues that haven't been addressed, such as looking at health programs within this frame. And in Liverpool in 2018, we focused on what has become known as the Health Financing Progress Matrix, which was really to provide more explicit guidance on implementation steps, and recognizing that it's not enough to have strategies. In that session, I started with this, and basically the starting assumption in the UHC discussion is that people understand it, right? And that when we talk about the definition of everyone being able to get the services they need of good quality and without fear of financial hardship, that everyone, or all people, literally does mean everyone, right? So there was this idea that if, countries, and we know there are many countries in the world that deviate from this perspective, and it doesn't mean that they're not doing health financing, but as we said then, it does mean that we're talking about financing for something other than UHC. So that was kind of the background, and that led us to much more, if there's agreement on the objectives that you're trying to achieve, then you could be very clear in terms of policy guidance. And that's what we've done, and really trying to frame things in this way on the technical side. But what's different, I think, now is really it's too much or too naive to assume that actually the core values underlying UHC are universally shared. And as we've often said, really pursuing UHC means that there is a redistributive agenda. And whenever redistribution is on the agenda, then we're talking about large political issues. And there's different willingness to redistribute in different societies. What we're also seeing more and more explicitly is a challenge to what might be called the social contract between citizens and the state, and especially with the rise of more ethnic nationalist parties and perspectives, that the whole idea is under threat to some extent. And we see that obviously with the attitudes towards refugees and migrants, but within societies and within country citizens, also those who are considered different in some dimension. We also have, and I think magnified perhaps by social media, real questions about the legitimacy of national governments and so on. So this is a question, and one of the questions is that, are these things really different now, or are they more visible, or are they more that people from the West, I would say like myself, are just being more, are recognizing this more explicitly? Next is to say, what is it that we're learning from COVID? And one thing is clearly that we've had a lack of preparedness, which can be seen really as a failure of collective action and political action in that sense. There are real questions that we have to face and start to deal with explicitly. For example, on the investments and activities for prevention, for preparedness, even if the benefits are not going to be visible within one electoral cycle. So what's the political strategy, in a sense, for doing that? Because it does need to be taken on. We're seeing different ways, both some successes and perhaps failures, in terms of how financing and payment arrangements were able or not able to adapt to support the response to COVID. So looking at where this worked and how and why or why not. And then on this potential opportunity from COVID, this line, which is true in a sense of such a large infectious disease crisis, that no one is protected until all are protected. So does this offer the opportunity to recognize that we're all in the same boat, in other words, to create a pro-solidarity message? Or the alternative, are we going to end up building more walls and more barriers within and between countries? So what we're thinking about in this idea of the new era, this idea of both the values being challenged more explicitly and the COVID context, that we know that it doesn't really alter the core knowledge that we have, or the concepts of what works and doesn't work in health financing. But for those of us, and I think those of you on connected to this event, who are really committed to UHC and the values underneath it, then we have to adapt our strategies. And one of those questions, broadly speaking, is whether to take and where to take a direct approach, where it can really work by taking on these issues of justice and equity and solidarity directly, or more indirect approaches to focus on technical things that help move the system and lay the foundations for universalism. But in those places, maybe the arguments to make are more on efficiency grounds than publicizing the equity grounds. And that's another reason why we're focusing on payment systems, because there could be a good opportunity there. And last is thinking about the role of evidence. And this challenge now that we all have of what is the nature of truth, in a sense, which is a big challenge. So how to communicate effectively, how to build the case for public policy, especially when legitimacy of governments is under threat. Do we need to rethink certain things that we've talked about and make it more of a focus of research? And I put this point about ownership, and historically, when at least I've written about this, the argument, especially in terms of service provision, was that, well, ownership doesn't matter if you get the incentives right, in a sense. But it's hard to get the incentives right, and people use their power and influence not to get the incentives right. And we also have this issue where accountability is to shareholders rather than to public policy. So what is the scope for taking this on as well? Again, building both the direct and indirect arguments, and then how to use evidence for policy and politics. And really looking at things, and I think when we hear a few later from Cheryl about this, who's winning from the bad policies and who's losing from the bad policies? I think this is really important to look at. So I'm looking forward to this, and I'm going to turn over to Agnes next, Agnes Sukat next. Basically, my own questions are, am I too worried about what's happening, or maybe not worried enough? How can we create these politically aware technical strategies? How are the issues playing out in different countries, and what are the critical research gaps? So with that, I'll stop and turn over to Agnes.
Thank you, Joe. Thank you very much for this introduction. So in this context, let's have a look of what maybe we may have learned from the COVID-19 crisis in 2020 and now. And the question that I would like to put on the table following your interrogations, Joe, is the question of whether the money that is spent on health, be it private or public, is actually buying what we collectively need to ensure universal health coverage, but ensure beyond that, a broader social contract and what it takes politically to rally the different segments of society towards what we need to do in common. And that includes preparation of societies to the future, whether it is the pandemic risk or environmental risks such as climate change. So what to buy after the storm? Before COVID-19 hit, the situation was already challenging, particularly in low-income countries. What we know is the past 2 decades, global spending has increased very rapidly, faster than economic growth, and that global spending is mostly domestic. When we talk about external resources, that's that little dot down here on the left of 16 billion as compared to a total global spending on health of 8.3 trillion, which is 10% of global GDP. What did this money buy? It's not completely clear. What we know when we look at the Universal Health Coverage Index, the UHC Service Coverage Index, we see that there has been progress on utilization of services, on coverage with services, but this progress has actually been slowing down over the past few years, particularly after 2010, and that it is very unequal, and that the Africa region, for example, still continues to lag behind. The slowing rate of progress was already a concern before COVID-19 hit. So when you see here, you see that there is this decline progress. So it looked like we probably had picked the low-hanging fruits of what we could do with existing health systems, but maybe we were not quite there when it came to further progress and identifying strategies for further progress, even in a context where economic growth was still providing some very strong benefits in terms of poverty reduction, and poverty was declining rapidly. This progress on coverage was actually very much driven by infectious disease and the progress that has been made on HIV and to some lesser extent tuberculosis and malaria. But actually, when we look at service capacity, which is the progress on health system capacity, that progress has actually been very slow and has mostly happened in rich countries and middle-income countries. There's been almost no progress in expansion of health systems in low-income countries. And when you look at the change in the capacity of health system over time, we see that this change has happened to very little extent. So what we've seen is health systems have not really developed much over these past 2 decades in terms of capacity. And when COVID hit and we saw that even rich countries had an issue with bed capacity, for example, hospitalization wards being overwhelmed or lack of personnel, this actually was exposing a situation that we knew was existing before. So what we've seen over the past 2 decades is that both government and out-of-pocket spending have grown, and that the relationship we find between the coverage with health services and funding for those services is essentially related to income and economic growth. We find no clear relationship between public spending and service coverage. It's really about the economy. Government priority have been strong on health in high-income countries and upper middle-income countries. But it's not been the case in lower-income countries. It actually declined. So the benefits that we've seen, the increase in health spending was linked to economic growth, to some level to a slight improvement in taxation, but was not linked to an increase in priority for health. And on the other hand, external aid has increased. It remains very small, as mentioned earlier, but it has also reached a plateau and has been stagnated since about 2013. More worryingly, as aid increased, actually the domestic priority for health has declined in those countries, going really at the fundamental question raised by Joe in its introduction of the social contract. What is happening in these countries if the priority that is given to health by governments and by society as a whole through domestic funding is actually declining, while at the same time aid had increased? Is there a connection? We know that there is a lot of evidence of fungibility, but this really poses the question as to why we find today that in fact private spending is the largest source of PHC funding. So at the time where we clearly define a road towards universal health coverage that goes to primary health care, we find that in fact most of the funding of the first level of care in the developing world actually comes from out of pocket or from private resources. And when we see the particular case of these past 2 decades of low-income countries, we see that the health spending growth was driven by external aid, but mostly by private domestic funding, not by public funding. When we look a little bit deeper and we drill down in that spending, we find that most of the spending that that was brought by both the aid funding and out-of-pocket spending went actually to commodities and increasing the availability of medicine, which has increased quite a lot over the period. But there's been very little investment in addressing what has been identified for several years now as the largest impediment to further progress on universal health coverage, which is the global human resource shortage. And here is the big question as to why. Why is it, if in fact money is chasing health workers, if citizens want services and want health workers to be delivering those services, why is it not happening that more health workers are trained and more health workers are funded to deliver and deliver services and progress on universal health coverage? So when you see here in the low-income countries part of this graph, that between 2004 and 2014, we have almost no progress on the availability of human resources in the entire Africa region. The density of health workers just remains the same. It barely keeps up with population growth. And we know that the labor market for health is globalized more than ever. This was when it happened between 2000 and 2012, where there had been really that acceleration of globalization of labor markets, the opening of the European Union, for example, with the free move of health workers between countries. But beyond that, we know that migration of health workers is happening between countries, within certain regions, within countries, between poor and rich regions, or between states, and of course globally between poorer countries and richer countries. And we know that there are now even broad agreements between countries such as Germany and the Philippines to organize the export of labor from one country to another. So what we observe is in the HRH situation is a textbook case of labor economics 101 of shortage. We have a very low supply of health workers, a high demand for healthcare services, and health workers have a lot of bargaining power, asking for actually higher wages. And we see that the ratio of wage to income in developing countries for health workers is much higher than in high income countries, because they can claim a high price, salaries, unofficial gains for their services. And it's very difficult to address, again, because of politics. And here is a big questions about the politics of UHC, which is the politics of human resources for health vis-a-vis the broader social contract, and how the dialogue is taking place between whatever barriers to entry there are in the labor market, which leads to not enough health workers, partially because of corporate reasons and different public policies that reduce the possibility of young people to choose health professions, and the broader question of the social contract, and the fact that health workers are often part of the elite of countries and may have interest in maintaining the shortage in order to maintain high income. But the trend is extremely strong in favor of continuous growth of health spending, with more and more demand, more and more technology being offered to respond to this demand. And we know that a country like the US, who approaches a fifth of its GDP, 20% of its GDP being driven by the health industry, we see that the potential of growth of the sector is immense, but it's not clear how it relates to the objective of universal health coverage, and how politics works towards the objective of actually distributing this very high share of GDP according to needs and according to choices of citizens, collective choices to ensure both that common goods are funded and that redistribution is happening. So when we look at the prospects of jobs in the future, we see that actually there are two categories of jobs that really are at the top. Is of course all the IT jobs. We clearly are in the fourth industrial revolution, and if anything, COVID-19 has shown the importance of IT solutions to the new economy. But also healthcare jobs are really among the top jobs that are offered to young people today. Yet, generally, in that context of shortage, there is a difficulty for job seekers to find people who have the skills. So what happened when COVID-19 came? It basically exposed all these weaknesses. It's been already often said that the COVID-19 crisis has acted as an acid test of health systems. And what we see, and that's the work done by the WHO team, is that in proportion, the low-income countries actually allocated more to the response to COVID than the high-income countries. Of course, because their budget is low, so any crisis is immediately a burden on the country. But the numbers are quite staggering in terms of percentage, because in low-income countries, we found that the response to COVID-19 could amount these are preliminary numbers because we will have the final accounting number only in 2022, but it actually shows that it could reach almost more than a third of actual budget in health, sort of overwhelming the capacity of the country in responding, in funding health services. We also know that the ways that COVID-19 may affect the health spending goes in different directions. It can actually, there are upward pressure that would COVID-19 because it requires more from the system. So it gets more things need to be done. So there would be more expenditure, but there are also a lot of downward pressure, whether it's the economic contraction, the decreasing FDI, the increasing poverty, the decline in government revenue, which is increasingly documented, and the fact that people not going to health services, the flow of income that would come to services through out-of-pocket payment is also not coming. So when it comes to this particular problem of the workforce, what we have is the pre-COVID-19 situation in which we already had a shortage, a COVID-19 response when the shortage was really exposed in a major way in all income categories. We saw that there was a lack of health workers, and that led to really drastic policies, including lockdown in high-income countries, because the health system was just not able to cope with the surge in demand, neither in terms of capacity in beds, nor in terms of capacity of health workers to man the emergency ward. Now that we are in the next phase of the COVID-19 response with the availability of vaccination, we have yet another massive requirement, which is to vaccinate first 20% of the population, then getting to the herd immunity, which is the largest ever vaccination effort that was ever envisioned, because we're talking about the entire population, not a segment of population. And this is again a burden on the health workforce. And there is not quite any view on how to address that problem and how to balance the fact that this workforce there will be trade-offs and there will be redeployments, and what will be the impact of that, and this will be very country specific. So if we get to the heart of this conversation today, so what is it that we need to purchase in the post-COVID-19 world? Clearly, all countries now, this is a common destiny, maybe for the first time in history, all countries face the same problem. They face a macroeconomic and fiscal vulnerabilities and likely increase in demand for services, but potentially a slowing progress on the road to universal health coverage because of both demand and supply factors. So we need really to do three things. First, we need to recognize the health system weaknesses and the failures. And I know failures is very much a taboo in global health. There is really this cartel of success. We always need to explore success, learn from success. But here we have a fantastic opportunity, sadly, to learn from failures, from collective failures of our pre-COVID-19 strategy. What did we not see? Where were our blind spots? Second, we need to assess country-specific impact. With all these forces going upward and downward, there will be no blanket impact. We cannot say that every country will be the same. More than ever, that's a message we've been saying a lot, but it's more than ever true that UHC policies will need to be country-specific, because countries will face very different conditions linked to the effect on growth, on trade, on poverty, on public revenue and taxation, on the private sector and its revenue from the purchasing agencies, etc. And the third one is the fact that we need to fully integrate the role of collective intelligence and collective action. Politics should not be a dirty word. Politics should be the beautiful the beautiful word of collective action. Politics is about that conversation that citizens need to have to construct the new social contract. And if, since all countries have committed to universal health coverage, if as all countries now are painfully aware they need to invest in common goods, there need to be a revival of that conversation to create a new trajectory towards universal health coverage, starting with the step zero. Step zero is investing in common goods, and then a PHC, primary healthcare-led road to universal health coverage. So we need to address the pre-COVID-19 blind spots with three main areas of action that require the right politics. The underinvestment in common goods for health, that's the tragedy of the commons. Only politics is the answer. Only collective action is the answer, because by definition, the market fails on these. So we need to revive and energize the politics for common goods for health. The second one is address the political impediments to investments in human resources. It is really puzzling that for so many years, for which we have recognized that there is a lack of investment on the supply side, and that almost every country faces barriers to entry, faces public policies that block young people to get training in health skills, that these policies are still in place. So there is really a need to have that conversation, that political conversation on how to scale up and step up the health workforce, what kind of workforce, for whom, and working on the workforce of the 21st century. And finally, the really question of the shift of global financing from an aid paradigm to a global commons paradigm. We've seen that the 20 years of global health growth in terms of aid funding of countries has gotten some good results, particularly on infectious disease, but it really has a blind spot, and that we really need to move away from a disease-specific framework to something that is much more oriented about investing in this common project of building institutions that will serve people's needs when it comes to access to services. How to steer that shift is really investment in politics, it's investments in citizens' dialogue, in societal dialogue at country level. So the key questions for post-COVID UHC that we need to answer collectively is how to trigger that collective action. How do we go about this? How do we foster this societal dialogue, this politics that work for the commons? How do we purchase essential public health function, which means how do we get that agenda of buying the commons, the common goods for health from the public purse, from the common purse? Second is which investments to address the global shortage of health workers, and how to address the politics of barriers to entry, the politics of training health workers, the politics of medical schools, the politics of investments in both public and private institutions that train health workers. And finally, how to address the blind spots of global health and move from a one disease at a time paradigm that we have been developing to an institution building paradigm that can respond to the problems of the future and address the disease of the future, whether they are new diseases like COVID-19 or old diseases that are resurging, like malaria or other infectious disease that may come back because of climate change and other environmental degradation. Thank you very much.
Great, thanks, Agnes. And now I want to turn over, to Cheryl Cashin. who will be our next speaker, talking about a very interesting experience she's involved with now, and broader than that. So Cheryl, over to you. And I think
Thanks very much, Joe.
Good. Agnes, you need to stop sharing.
Great, thanks, Joe, and thanks, Agnes, for setting the global stage so well. I'm going to take us in a bit of a different direction, back down to a very local level, and talk about some experience in the state where I live, in the state of New York. So my name is Cheryl Cashin, and I'm a managing director at Results for Development, and in that role, typically work on global health systems. But I have become active on the other side of the table in my state to work on passing some legislation for a single-payer universal health coverage bill that would provide access to healthcare for all residents of New York, and have really encountered a lot of the issues that Joe has raised in the opening presentation about navigating politics and some of the issues around redistribution and, as Anya said, the social contract. So I'll share a little bit of the lessons that I think do have some global relevance. Just want to make sure that everyone can see my screen. So just to set this in the stage of the COVID-19 pandemic, and so asking the question, is this crisis an opportunity for change? And we really, I think a lot of us working on this issue in New York really thought that this would be a game changer. This pandemic just exposed so much. And we found that it didn't change the game in the way we thought, but it did give the opportunity to make some different arguments. And that's what I'd like to share today. So just a little bit of background. I think most people know that universal health coverage in the United States faces a lot of challenges, and many efforts over many decades have been impeded by what I would say is a deep cultural aversion to redistribution through taxation and a glorification of private actors in all parts of the economy, including in the health system. We have in New York gotten a pretty practical solution on the table. I think looking at it from a perspective of a health economist, it is really what I would say is best practice. This bill has been around for about 2 decades, so it has gone through many revisions and really thought through everything about how to practically introduce a single-payer universal health coverage system that has comprehensive benefits, is funded by a progressive payroll and wealth tax. All the analysis shows that it would expand coverage, the depth of coverage, including long-term care, dental, just really better coverage than any of our best coverage plans out there today in the United States for less money. So this is really, if you look at it from a technical perspective, it's a no-brainer. But it hasn't gotten as much traction as we would think. Even over the many years, it has passed one house of our legislature 4 times. It has really been around. And I look at, even since I have been part of trying to advocate for the passage of this bill, we've been taking 2 approaches. One is to try to convince people that this is such a good bill, convince people that you would get better coverage for more money, and make those technical arguments, using the global analysis that's been done by think tanks such as Rand Corporation looking at the state level. And kind of telling the sad stories that our system is so bad, people are so hurt by our system today, and this would improve equity, make everyone better off. But the opposition has remained strong, and people are afraid of giving up what they think is the good coverage they have now, although we know that coverage is good until you need to use it in the United States. The unions have been very much opposed to this bill, saying they have negotiated away higher wages for a long time for their health benefits that they have today. So what is the opportunity? I think the opportunity in the COVID crisis has been for us to look at how to reframe those arguments and find out what really makes a difference to people. So I'll share a little bit of that with you today. So first, we know that the COVID-19 pandemic has exposed the deep structural flaws in the US health system, tying health coverage to employment when we had 20 million people unemployed at one point. Our for-profit insurers eating up 18% of every dollar that we put into our health system in profits, marketing, administrative costs. And that's not even counting the administrative burden on providers and the fee-for-service payments that are fine for providers when they're delivering a lot of services. But as we saw during the early days in particular of the pandemic, when they weren't delivering services, they weren't getting any revenue. And finally, a massive transfer of federal and local tax revenues to insurer profits. But what I don't think people were also seeing is what we have given up by putting all of our health financing through private insurers is the ability to use the money that we prepay into the system as a strategic public asset, especially during the time of a crisis. And so during my day job, I was able to talk to colleagues in South Korea and how they were able to mobilize their funds in their single payer system to direct to where it was needed most. They were able to add the COVID benefits immediately to the benefits package. Even though they pay providers fee for service, they were able to increase the rates, as they said, 60 to 100% to make up for the lost revenue when people didn't go and seek care or elective services were canceled or postponed. Meanwhile, back home in New York, we were not able to get protective equipment out to our nurses and doctors. There were huge staff shortages. They were not able to move money around to where there were big outbreaks and where hospitals were overloaded. Tents were being put up to provide excess capacity for hospitals. And this picture of a doctor wearing a trash bag, we saw more than once, even in my hometown. So there was so much that was given up. But if we look more deeply, we could see that at the time all this was happening, there was a massive transfer of funding in our system, even more than usual, from premium payers, individuals like us, from our health providers, and from the federal and local government budgets to insurer profits. And this was released after the first quarter of 2020. We started to see that 2020 was the most profitable year ever for our private insurers, that they made record margins in all of their markets, but they've made particularly high margins in those last two sets of bars in 2020 in the public program markets. The Medicare Advantage, so where the government pays for coverage for the elderly, but they're doing that increasingly through private for-profit insurers, or through Medicaid managed care, which is the government program that covers the poor in the United States, also increasingly engaging for-profit private insurers. They made margins over 100% in 2020. A huge transfer, a huge redistribution of funds from people to profits. And a lot of that money we were seeing was also coming from reduced payments to providers because of services being delayed, elective services being delayed. There was a survey in the state of New York by the Medical Society of New York that showed that 80% of healthcare providers, private practice providers, had a revenue loss of more than 50%. So they were really suffering. We're not even sure what the long-term impact is going to be of this revenue hit on the private providers, while the insurers weren't paying out and were sitting on those profit lines. So there's also a transfer of funds from the federal and local budgets through the relief packages that were happening in response to the COVID pandemic. So there were two big responses to provide health protection to people who were losing their jobs that were meant to increase access to insurance, but also at the same time resulted in a massive transfer of funds to private insurers. And these two here are increases in subsidies for people who were purchasing insurance on the market exchange through the Affordable Care Act. So increasing the amount of subsidies and lowering the income threshold at which you were entitled to a subsidy that allowed you to purchase the coverage through the private insurance market. So that was actually funding $35 billion going back to private insurers. And another, in the most recent aid package, increasing a subsidy for a program called COBRA, which allows someone who had employer-based coverage but loses their job to continue buying into that coverage out of pocket, which is very expensive. Very few people actually take advantage of that program, but some subsidies were just added to allow people to get that access for free for the next year. But that again is another subsidy going directly to the private insurance companies, with only 2.2 million people benefiting from a $36 million expenditure, about $15,900 per person. Again, transfer from the federal government budget to private insurers. So all of that's happening at the national level. We started to look at the local level in New York. What was happening to local budgets? And this is where the unions come into play, because our local county and state governments are paying for healthcare for the union members at the time of their employment and well into their retirement. And so a couple of researchers who I'll acknowledge at the end put together a simulation model. What if this coverage was provided through the New York Health Act at the estimated tax rates that would make that program viable? And they went through and looked at all of the salary information and did a simulation of what that tax burden would be versus what the burden is today on these budgets of purchasing coverage for employees and retirees through the private health insurance system. So here's just a picture from my county where I live, Suffolk County, New York. And the bar on the left is our current property tax revenue. The next bar is how much of that goes to paying for insurance for county employees who are in the public unions and are guaranteed this coverage. And it is more than 60% of the property tax revenue is going just to pay for coverage for county employees. Of course, the county gets other revenue, but the property tax is a highly hot political issue, and people are always complaining about their property taxes in Suffolk County. But if the county were able to cover employees through the New York Health Act, there would be a savings to the county budget of $382 million a year. And that comes out to about $780 per household. That's excess money that's going into the for-profit health insurance industry to provide worse coverage than the New York Health Act would provide. And because of the hits to the local budgets, because of the COVID-19 pandemic, even this expenditure is not enough to maintain the comprehensive coverage that the county employees are used to, and they've had to pay out of pocket for the first time this year to keep their coverage. So that's the tax payment that comes from us, and they're paying additional out of pocket for that coverage. And the issue of schools has been also very political during the pandemic. The school closures and the unions, the discussions between the unions and the community members about when reopening can happen, how does reopening happen safely, schools saying they don't actually have the funds to reopen safely in many cases. But again, if we look in their budgets and apply the calculator of the New York Health Act against the payroll of one school district, Huntington School District, which I understand might be someone on our panel school district, this excess expenditure is really unbelievable. From $22 million on health coverage for school employees, for teachers and others, not even counting the retirees who are covered before they reach Medicare, they could save 75% of the school expenditure on health coverage through this progressive tax funded system. So this is a picture that was just my county. This picture is the same all across the state. There's a lot of socioeconomic variability in New York. So even in lower income areas, higher income areas, the picture is the same. That the savings to local budgets, to school budgets, goes anywhere from 70 to 95%. That's the excess spending that is going into private coverage for public servants, teachers, and other employees at the local government level. So what has this meant for our discussion on the New York Health Act? So we have found that these kinds of analyses have resonated much more and very different to early on in the year when the pandemic first started, when there wasn't much change in public perception around the New York Health Act in New York or in health reform in general in the United States. We're seeing a much different conversation today with these kinds of analyses available and the discussion centering on locally generated data, local budgets, and local tax payments has really changed the conversation. And I had to update my slide yesterday because just yesterday the bill was reintroduced into the New York State Senate for the first time with a majority support. So there are 33 out of the 60 senators in the state now are coming out in support of this. So there's much greater chance that this might actually pass. And so we think a lot of this has to do with really reframing the discussion on redistribution, reframing away from the discussion on equity and improving access for everyone to really making it about redistribution from your tax payments into private insurance coffers and as we saw in 2020, into their profits. And also bringing the discussion around to the opportunity cost of these excess payments. We could have a system, if it were tax funded, you could save a certain amount that could be redirected to other priorities at the local level. What has resonated, at least in my county, is expenditures towards school reopening and improving schools. So just to end on some lessons that I'm taking away from this back to my day job, what are some lessons around the policy and politics of UHC? That the crisis can always open a window of opportunity, but we have to use it in the right way. And it isn't always in the way that we think. We have to look for what is the way that this opportunity is created to reframe the conversation. And in this case, the redistribution that was already happening in our system from tax dollars to private insurance profits became so exacerbated during the pandemic that it created the chance to really reframe this in New York State. And the political arguments have to be context specific. The equity arguments don't always resonate in the US, and how to get the arguments framed about people's tax burden, where the tax burden is going, and what the opportunity cost is of that. And then using local data analysis that directly links to people's priorities that are at the local level. So people knew this data, they understood the Suffolk County budget numbers, they see that in the local newspaper, they understand school budgets, and to see the impact on that of this state level legislation really changed the conversation. I just want to end by acknowledging my colleagues and friends who did all this analysis, who came up with the simulation model and presented the county level analysis that has been now taken all around the state to have these very specific conversations that I think is having an impact on the politics. Thank you.
Great, thanks, Cheryl. And we're going to take a few minutes for questions. There's one in the Q&A box from Allison Morgan. This was for Agnes, and I have a question also for the speakers if we get to it, but let's see if more come in. Agnes, the question was really wondering what you see as the main constraints that result in this situation with HRH in Africa. If you could look at the question, knowing there's issues, concerns raised from the experience in Nepal and the number of posts not increasing. And so wanting to hear how you think that could be addressed, also with some reference to Ebola. And Cheryl, actually for both of you as well, what I was also trying to think about was, and it connects a bit, the financing and the HR issues. I mean, Cheryl showed the real magnitude of savings that could be found, but the issue is always that savings might translate in part into jobs. And so even if they're unproductive jobs, needing to think about the politics of that. And I was reminded in some of the experience in South Africa, part of the resistance to the national health insurance reform was thinking about the implications for the stock market, for example. So just trying to think of how we bring that in. But anyway, let me turn over to Agnes and then maybe Cheryl to reflect on that. And I see a couple of people with hands up. I don't know if we're able to open the microphones to the floor. If we can, that would be great. But Agnes, over to you, and then we'll see what we can do with the hands.
Thanks. Yeah, no, it's really a central question. And what we find when we look at the data, and increasingly over the past 10 years, we've developed more and more labor market analysis in different countries, particularly in low-income countries, and many of them in Africa. What we find is a really chronic under investment in training of health workers. You would typically have a country of 70 or 80 million people who would train 100 doctors a year or 200 doctors a year. And they say, oh, we don't want to train more because they leave. Well, if you have 80 million people and you train 200 doctors per year, basically it doesn't matter whether you have 10 of them or 50 of them leaving. It's just 200 is just not enough. So there is no recognition of the significant underinvestment on actually training the right numbers in a context where you have a rapidly growing population. So the disconnect is actually increasing because there is no investment in medical school or nursing schools that go a par with population growth, which is extremely rapid. And at the same time, you have economic growth, you have demand. People are looking for health workers, so they turn to informal workers who provide services, less than qualified providers, because there are no qualified providers. And then the second reason is that there is this sense in many countries that only governments can actually invest in this pre-service training. It's less true for nursing schools. There are a lot of private nursing schools, and a country like Ethiopia has really done amazingly well in actually developing an accreditation mechanism for those private schools and rapidly increase the number of available nurses on the market by improving the quality of the training of these nursing schools through improving the standards, establishing a national exams that these privately trained nurses would have to take to work in the public sector, receive public subsidy. So, but generally, there is no real policy to scale up in a major way the health workforce, while in fact, we are in a context in most of these countries of having money chasing health workers. And this is the reason that you actually have low execution rates of many budgets, many also donor projects, with aid money competing for a rare health workforce. And the third one is really about the model of training, because the scarcity of health workers is of course much higher in rural areas, in peri-urban areas where the population is poor. And there has been no real a massive effort to really develop curricula, institutionalized curricula for health workers that are actually coming from those areas and will therefore stay there because it is their home region. And we know from the literature that this is the way to go. This has been demonstrated in northern Thailand back in the time. This has been demonstrated among the Inuit populations in Canada. It's happening in the US. What is important, it's happening in Australia. What is important to create cadres of health workers who are both motivated and trained to provide services to people in remote areas, or people who belong to the low income part of society, is really to train these people within the environment and to train them for the issues that they need to address. And there is a whole movement towards that, but in fact very few countries are building that into national policies. So you basically have UHC policies which are focused on financing, which are focused on benefit package, but on the other side of the equation, the supply side, the service delivery, is very little addressed, and particularly the fact that you just don't have enough trained health workers, or other cases, particularly in South Asia, with I think Pakistan recently, where we did an analysis of the barriers to universal health coverage, where you see, as I was mentioning, that most of primary healthcare is actually provided by the private sector. But that private sector, there is no accreditation mechanism. There is no mechanism for public money to fund them, to provide services. So in fact, there is a UHC PHC policy that is happening just within the space of a publicly provided services by a public provider, which actually serves only a small fraction of the population. So there are different types of policies like that, but I would say that the most successful policy that we have seen is really whether it was in Thailand or in Ethiopia, to really crack the problem of scaling up the training and opening the schools, both the medical schools and the nursing schools, to more students, and particularly students from rural backgrounds.
Okay, thanks, Agnes. Cheryl, do you want to come in quickly? And sorry, it looks like we're not able to open the microphones to the participants from what we're told. So sorry about that, but if you can type, if people can type things in, we'll have another Q&A session at the end. But Cheryl, please.
Thanks, Joe. And I think I'm recalling you saying actually that one person's efficiency gain is another person's income loss. And so this is certainly the case here. We have a lot that insurance industry does employ a lot of people in New York. And that has been taken into account in the bill, that they tried very hard over the many years that this has been refined to try to address all of the potential losers. I don't know if it's adequate. You know, retraining is kind of a vague olive branch to give, but I will say whoever loses their job because of this won't lose their health insurance.
Great, thanks, yes. And we hope it works. And yes, I'm the guilty party that you're talking about, not only my state and county, but my school district as well. All right, we want to turn now, and again, there'll be more time for discussion towards the end. We want to turn now more towards country experience and implementation challenges and the real, more real world of that. So we're going to start with Dr. Wangari Nganga from the Presidential Policy and Strategy Unit in Kenya. Wangari?
Thanks, Joe, and thanks a lot for putting me after all the technical speeches so that I have the very brilliant chance of displaying how much my technical knowledge has eroded. But it's really good to be with you all, plus the attendants, even though virtually. My name is Dr. Wangari Nganga. I work in the Presidential Policy and Strategy Unit here in Kenya in the Executive Office of the President. As some of you may know, our President, His Excellency President Uhuru Kenyatta, has declared himself on 4 social transformative agenda, one of which includes universal health coverage. So I've spent a lot of my time thinking and somewhat doing what Joe and Cheryl and Agnes have discussed previously, which is finding a way to marry the technical objectives of UHC with the political space. And perhaps maybe that's where I actually want to start my comments from and pick up from something that Agnes asked, what have we learned since COVID? And one of the very obvious observations has been the realization that we have to consider what social safety nets look like for us here, like in a country like Kenya, and I guess for the larger LMIC. So when we first had the first lockdown, which was between March 2020 and August 2020, when we closed even international borders, a lot of economic activity stopped. As you may be aware, economic activity this side of the world is mainly through the informal sector. So when you stop businesses, even informal ones, then you need to ask yourselves, what will these people eat? So even just the logistics of bringing the food to them, if it was going to be subsidized, that's one. But where will they get money to buy this food? And so the question around bigger social safety nets, bigger, broader, perhaps the word is broader as opposed to bigger. And the question then becomes, then have we been siloing health? Even when we are all signatories to the One Health approach, it's more of ensuring there's a health lens to other agenda as opposed to seeing it as one of a part of many. And so this question has really been on the minds of several countries, actually. I've been privileged to see several post-COVID economic recovery strategies from countries in West Africa, from countries in Southern Africa, and from ourselves as well, where there's a strong consideration of what do social safety nets look like. So in Kenya, we went with a cash transfer program with a incentive that this maintains the supply chain all the way down. But as we would know in the health sector, we would prefer, at least in terms of efficiency, to prepay for health as opposed for people paying out of pocket. But that became a very interesting dynamic to think about. In as much as we've been preaching universal health coverage, where do the other areas that of social security lie? Perhaps the other question, which is probably broader than COVID, would be how responsive have our technical inputs been in the political space? So our president, His Excellency Uhuru Kenyatta, has been making incremental gains towards some sort of universality, towards some sort of financial protection, increasing quality of service through the removal of user fees at the primary healthcare level, through the introduction of free maternity services, through the introduction of free services for high school children, incrementally. And now we're at a stage where we're considering universal health insurance coverage, mandatory for those who can pay, and a full government subsidy for those who can. But it's taken us very long, and here I'm speaking as a person on the technical side, to be able to respond with a technically sound response within the political timeframe. And now our time is running very short, so we're just almost there. We're starting with 1 million households. We've got 700,000 registered to date. We're hoping to close this out within the next month or so and roll out that part of our UHC agenda. But every time we sat down to discuss, we were very clear that, where are we on the health benefits package? Where are we on our purchasing arrangement? Where are we on 1, 2, 3? All the technically sound arguments, all the technically sound considerations that we should be making. But I think it's important to reflect on what the timeliness of the technical response is vis-a-vis the political calendar. And when you have the attention of the highest office of the land, and to kind of, and I think Agnes mentioned this in her interrogation as well, to kind of change lens and not see politics as something we need to add into the process, but politics being collaborative action, politics being what drives citizen participation, politics being what then drives the collective purse, which means politics is in the center, and really our technical inputs are to surround the politics as opposed to the other way around. It's not for the politics to integrate in our technical work. And so questions such as what role does the technical space play in the political world as opposed to vice versa, which is probably how we traditionally approach this. So these were some very interesting perspectives for us to consider. Moving forward, we are now again in a very heightened political space when we are discussing the Building Bridges Initiative and constitutional amendments, which we feel are pretty crucial at this point. As some of you may know, Kenya also runs a devolved healthcare system. And so there's also, beyond national level politics, we have county level politics and the county assemblies, and how all those, play into the specific agenda we are trying to drive. Joe, I think I'll stop there and perhaps hand over to Sheila.
Great. Thanks a lot, Wangari. Really interesting comments and challenges, I think, for all of us that hopefully we'll take up soon. But Sheila, let me turn over to you for your input.
Thank you. My name is Sheila Doherty, and I recently left Apt Associates after about 25 years, where I was living and working on health reform in Central Asia and Tanzania. I'm going to comment on working below the radar, building universality and strengthening accountability. I'll talk around this one slide, everything. I'm not going to go line by line through the slide, but I am going to try to make a few points around this one slide. In international development, practical step-by-step help program or reform implementation often flies under the political radar. This is kind of the other side of the coin of what Wangari was just saying. But when it is explicitly built into the equation, one of the questions becomes what technical program and sequencing opportunities can arise? What contributions can be made to both universality and accountability? Many implementation experiences and lessons learned have emerged to guide countries worldwide in their journeys towards universal health coverage. One is a shift to output-based health provider payment, including for general revenue funds, to better match payment to priority services and better target the poor and underserved. Another is igniting service provider management to assemble inputs, not just focused on the inputs themselves, but somebody has to assemble the inputs and to manage delivery of service outputs to their patients and communities. Just imagine a car manufacturing assembly line. You know, somebody has to care about the car rolling off at the end. And if you focus only on inputs, you get 2 steering wheels and 3 tires per car. Assembly of inputs is done by the service provider and their management is critical. In other words, the discipline of management is inherent at service provider level. It often just needs to be unleashed or kindled. In both of these technical opportunities, a new intersection of health purchasing and public finance management has emerged as vital to working under the radar to contribute to universality and accountability. I won't go through all the details of the chart on the screen, but you can see how health purchasing and PFM, or public finance management, can work towards improving both financial management or financial control, as some people tend to term it, rigid control of money, and health service delivery on the road to UHC. Over the last 25 years, I think this middle ground has emerged and even been solidified. Health financing specialists used to complain about barriers and rigidities in PF systems, hampering both financial risk protection and service delivery. And then the PFM specialists would complain about off-budget health funding or fragmentation, including of donor funds. 2 implementation examples from that kind of represent this new intersection. The first is efficiency gains in post-Soviet Central Asia, Kazakhstan, Kyrgyzstan, Tajikistan, Turkmenistan, and Uzbekistan. A core system problem was excess hospital capacity, and it was fueled by input-based budgeting and provider payment. Hospitals, or really the entire health sector, would lose funding if they downsized or found other ways to save money. Shifting to output-based payment enabled hospital restructuring, creation of savings, reinvestment of these savings in strengthening primary health care, direct costs of patient care, and extending service coverage. Over time, the countries expanded this strengthening of health purchasing and resulting efficiency gains into broader health reform dialogue. Just to clarify quick, as there's some confusion, there are many types of output-based payment, and it includes fee-for-service, global budgets, primary healthcare capitated rates, case-based hospital payment. What we're really talking about is a very, very rigid line item input-based payment system, as not enabling some of this under the radar program implementation that really tends to focus on bringing efficiency gains. A second example is Tanzania's specification of direct facility financing, which included both a shift to output-based payment and nationwide extension of planning and budgeting and accounting and reporting systems to all public health providers. Really all public health providers and schools, meaning 25,000 new entities were able to better manage their public services. This new intersection of health purchasing and public finance management enabled health provider autonomy and accountability to walk hand in hand, and also ignited health provider management and service delivery, which is key to equity and universal health coverage. In both of these cases, harmonizing health purchasing and public finance management drove rapid nationwide implementation and immediate institutionalization for sustainability. No pilots, immediate national implementation, immediately in government systems. It also drove harmonization of both health and financial management information systems and better use of data for analysis and decision making. A related technical opportunity that can also fly under the radar is the use of unified provider payment systems. I think this is part of what both Wangari and Cheryl was referring to. This means that the same payment systems are used for different funds flows. They can reduce fragmentation and help mitigate pooling problems and associated equity and financial risk protection risks in the short term. Unified provider payment can accomplish two things. First, to give service providers the same incentives to serve all patients, which is key to equity, financial risk protection, and UHC. Second is to massively reduce administrative costs and increase efficiency by the use of the same payment and information systems, even if the funds flows remain more fragmented than optimal. I'm going to add one point here to kind of what the comments I was going to make to add into the human resources discussion. There's a major dilemma that emerges in the health purchasing and PFM intersection. After setting hospital payment rates in the US Medicare program and working on post-Soviet reform, I was literally shocked to learn that many lower and middle income countries in Africa and Asia do not include labor costs in their output-based payment for health benefit packages. The dilemma is that on the one hand, it's great to have public taxation or general revenue support for health civil servants. On the other hand, the disconnect in paying for labor versus other operating costs creates huge efficiency and productivity problems, even to the extent of questioning some of the numbers on the shortages. This is my personal experience that I felt some of the shortage numbers were questionable when health workers sit without patients because there's no operating cost to pay for patient care. So a technical opportunity that really hits some of the HR topics that were discussed in this session is to implement purchasing of health benefits package with provider payment, including both labor and other operating costs, such as supplies and drugs. And this is absolutely as true for paying public providers as it is for paying private providers. In conclusion, there are many ways that technical program implementation and its management and sequencing can start and accelerate work under the radar. Experience has shown in a positive sense in our current world that technical progress can later emerge into surprisingly positive policy and political space, thus enabling further movement towards universal health care. Thanks for your time and handing back.
Thanks, Sheila. Really helpful. Great to hear all of that. It brings back good memories as well. There's been some really good questions also coming in the Q&A. We're going to come to them soon, but first we want to go on to the next part of the program, and then we'll come back at the end to the questions, and perhaps some of our next panelists will address them as well. We're going to start with Susan Sparks from our WHO team. Susan?
Hi, thank you, everyone. So my name is Susan Sparks. I'm on the health financing team in WHO in Geneva, working with Joe and Agnes and other colleagues who are on the line. So it's a pleasure to be here. And so we were asked to come in at the end to give a bit of reflection in terms of research priorities, but also sitting where I sit within WHO, it's also in terms of kind of technical support priorities related to this issue of blending the political with the technical, and what does the political really mean in light of the current context and priorities, and really how to push some of these questions forward, I think, related to UHC, because I think there is a bit of a concern about progress getting stuck and what does that mean, and unpacking some of these issues. And so I've split my reflections into 4 pieces. And so just for full disclosure, I'm deeply interested and have a real agenda around pushing the political part of health financing reform and health sector reform in general, and becoming more comfortable with these issues. And so I think it's probably a reflection of perhaps it's COVID times, or I'm not sure what, but I've been doing a bit of reading, looking at kind of the origins of politics and political economy. And I actually found that Aristotle's definition and discussion around politics really useful, in this notion that politics are people coming together in political communities to have a good and a happy life, for this virtuous purpose. And so the reason I like this notion of politics, particularly from a research perspective, is that it grounds the notion of politics in the end user and in the beneficiary. I think that oftentimes when we talk about politics, it gets caught up at the level of the executive and at that power brokering level. But then in thinking about health financing reform or health workforce reform in terms of the actual beneficiaries, whether it's the health workers themselves or it's the actual end users, I think then that can help in kind of translating some of the focus onto that collective action issue. So this first part is really understanding politics and who's actually involved in those politically oriented discussions. And then the second part is how to better embed political economy analysis, but also in really in reflecting on what Wangari said, is maybe also embedding more of the technical analysis into the political, and that having more of this two-way street. And I think that oftentimes politics are viewed within our technical community, whether it's researchers or practitioners, as a bad or a political constraint or context. And for me, I think we really need to move beyond that notion. And COVID-19 has certainly laid bare the fact that the political and the technical in public health. And I think this is where, if you bring it back to Aristotle's definition, anything that involves people in a community is going to inherently be political. And so moving beyond this notion of this is context into saying, no, this is part of the policy. This is part of the technical. And in that way, it enables the technical, as Sheila's reflected, the technical becomes a tool for the political, and kind of selling that. And I think Cheryl also is how you use that evidence for politically informed dialogue. And I think that that's really important to have that two-way street. And particularly on the research front, there's so much to contribute in terms of how that messaging, how the technical evidence can lend itself to the political dynamics and vice versa. And the third point is really on unpacking this notion of politics and the political economy. And I think just like health financing and work that Joe and others have done in terms of unpacking the functions of health financing, also we need to really unpack this notion of the political, because it involves a number of different factors, whether it's institutions or agenda setting or resource distribution or social participation. And so from a research perspective, matching what notion of political context or political questions or issues and frameworks that can be used to the research objective and the strategies. And so I think that's also really important, because you wouldn't want to come into, for instance, an example that we have is in terms of our work in supporting the development implementation of health financing reform strategies. The messaging isn't necessarily, or the key issues aren't maybe around changing the nature of the social contract in terms of short-term technical advice to ministries of health, but maybe it more is about understanding the different constituencies, the bureaucratic politics, what is the different factions and issues within the health workforce, who are the different players involved. And so kind of matching the notion of politics with the actual technical questions that we're looking at, and having those two really go hand in hand. And so I think this unpacking is really important as we move into this space of becoming much more comfortable with the political, I think, in terms of global health experts. And then the last is to really use political economy. And so I think Wangari's reflections were really very powerful. And I think anybody who has read or listened to Barack Obama's Promised Land knows that, I mean, it's a fascinating chapter. If you haven't, I really recommend listening to the chapter on the negotiations around Obamacare. And what we know is, particularly once you get above the radar, so perhaps under the radar is a different question, but once you get above the radar, a lot of last minute decisions get made. And how do those compromises, what are those compromises, and how can we as kind of people who are engaged in the technical side make sure that what gets negotiated at that level doesn't have a negative impact on the actual objectives related to UHC, is all the notions that Joe talked about in the opening. So I think that's really important in how we understand and are able to engage in those compromises and strategic decisions as well, and provide that technical advice that's also politically sensitive. So those are my reflections. Thanks so much.
Great. Thanks a lot, Susan. Really interesting, and something, again, that we're trying to build more into our work, but has to be, has to really take center stage, I think, increasingly. I want to turn now to John Ataguba from University of Cape Town. And John, if you could unmute and offer your reflections.
Thank you very much. Thanks, everyone. Good afternoon, good morning, good evening, depending on where you are. I'm John Ataguba at the Health Economics Unit, University of Cape Town, where I teach health economics. I'm currently the director of the unit. For me, the whole concept of UHC is something that we all agree to, or I would argue. However, the challenge is that sometimes we fail to also sit back as researchers to look at other factors that surround UHC. For example, one that comes to mind is the social determinants of health, which in a way has come out of all discussions we've heard so far. Let me start by thinking, one, we know that primary health care is being driven largely by, has a very high utilization rate. Okay, people use a lot of primary health care services. Now, if you go to hospital services, the major driver there is now costs. So in a way, many people use primary healthcare services, and even though many people don't use tertiary services or hospital services, the cost is very high. Now, what that means, or what these two things mean, is that we need to begin to look at what even causes, one, utilization, and two, the costs at hospital levels. And the surgence of non-communicable disease would basically point to the fact that we need to look at the social determinants of health. And that means we as researchers can begin to think of how we can lobby other stakeholders beyond the health sector to be able to reduce as much as possible the burden of disease. Because by the time you reduce the burden of disease, for example, you reduce utilization rates at primary healthcare centers, as well as reduce government spending, or even any spending, government or private spending on hospitals. Unfortunately, many African countries, and it seems to be the same across many countries, hospitals are usually where the largest share of health spending goes. So the hospital-centric also deal with, if we begin to think carefully at the social determinants of health. And for me, that's one thing to do as researchers, to now think of how then do we kind of bring in that within the UHC debate to complement UHC and of course reduce global health spending tremendously. A couple of research that I've done showed that by the time we invest in 3 key sectors, and WHO also came up with those sectors, one being employment, 2 being education, and the 3rd being the environment, broadly speaking, are things that can reduce global health spending, and they are fortunately cost effective. But unfortunately, we as health economists, most of the times we focus on waiting for the health sector to be bombarded, and then we deal with the case rather than trying to avoid them from coming. And that brings me quickly to the question raised by Felix. Felix talked a lot about HR in Nigeria, my home country. Okay, now the issue with HR in Nigeria, like many other developing countries, is the fact that people leave, people don't come. And it has a lot to do with the economy. Not least that the health sector doesn't contribute. But the economy itself is something that we really need to deal with. It comes back again to the social determinants. What are the things that determine many of the factors that we're dealing with? One is the economy. If Nigeria is a flourishing economy, instead of people leaving the country, people will come. So one should begin to think of those broader factors over and above the health sector to begin to push countries towards universal health coverage. So we should look at, I would argue, the social determinants of health and put a lot of resources into researching how we can make governments and key stakeholders see the importance of these social determinants of health in moving the UHC agenda forward. And lastly, I would also want to add that when COVID hit our shores, many African countries, what they decided to do, which was obvious because things were happening rapidly, they had to reprioritize because they didn't take lessons from Ebola, for example, into account. Many health systems were ill-prepared. The so-called preparedness function was thrown out, and resilience was nowhere. We have talked about many of these things long before now, but it seems like it's just an academic exercise. So we now again need to make sure that countries begin to use this COVID-19 pandemic as a way to begin to think of making health systems resilient as well as make them sustainable and strong for any shock. COVID-19 will not be the only shock. We pray it is, but unfortunately things happen. It may not be the only shock. And the sooner we get ourselves ready as countries and as people who are interested and have vested interest in the health sector and of course health of the populations, the better it is for our countries. And with that, I'll yield. Thank you so much.
Great, thanks a lot, Sean. You really raised a lot of important issues. I mean, I was thinking when Wangari was talking also about getting health out of a silo. I mean, we often talk about, we're often so much in our own sector that we're dealing with the silos within the health sector, which are important and large, but the wider public policy response in dealing with the social determinants has been made so evident by what's happening with COVID. I think that it's really critical. But let's now turn to our last speaker, Kara Hansen from the London School of Hygiene and Tropical Medicine, to help pull all these pieces together. Kara?
Well, mon Dieu, that wasn't what you asked me to do.
Surprise.
So what an interesting set of ideas from all three kind of sets of presenters, thinking about the kind of the technical arguments, the implementation arguments, and then starting to think about some of the research issues. Kind of sitting here in the UK, one of the things that's been really interesting has been watching this deliberate effort to separate the technical from the political decision making around COVID policy in particular. And I couldn't even begin to count the number of times I've heard my technical advisor colleagues say, well, you know, that's really a political decision, and all we do is provide the numbers. And I think I guess I would kind of echo Susan's thoughts on this, which is this separation, our insistence on separating the technical from the political, I think is not going to serve us well when we are trying to create and recreate and continue to infuse our movement for UHC with new energies through what is going to be a very, very trying macroeconomic period, both for, you know, at the national level and at the global level. And so I was just kind of thinking about, you know, are we as analysts, as researchers, providing the information to that decision-making process that really enables those trade-offs to be made? And that also made me think about the tools. So I really enjoyed kind of Cheryl's points about maybe needing to shift the argument, not from equity to efficiency, but bringing an equity lens to the efficiency question and looking at problems of of the distribution of efficiency gains or the distribution of terrible, terrible inefficiencies. And it did make me wonder when I think about the toolbox that I use as a health economist, the sort of the tools of distribution analysis and concentration indices and equity ratios. Is that the right set of tools to be bringing to these decisions? And similarly, our tools of efficiency analysis are very blunt. They tell us kind of not very helpful numbers like 30% of resources in the health sector are wasted, but they don't necessarily tell us where the realizable gains are. And they don't tell us very much about the distribution of those realizable efficiency gains. And I thought that the points about the role of the private sector and in the case of New York State, of the private insurers, but also Joe's questions at the very beginning about our agnosticism about the role of private providers, is that founded? Should we be actually really looking at these issues of the distribution of profits and the distribution of margins and being more critical in terms of the accountability of different types of organizational actors? And then just on that same vein of tools, I guess, I listening to both Agnès and Cheryl speak, I was thinking, gosh, as health economists, I don't think we bring enough public finance or enough labor economics into our thinking and into our research. And so if I was looking to new areas of economics to feed into these analyses, it would be to be much smarter at public economics and fiscal policy, and not limit ourselves to these rather narrow questions about how do we raise money for health, but really engage in a broader range of fiscal analysis. That brings me to two issues that I think are important ones to continue to research. So one is about all of these issues in the context of decentralization. And so, when I hear Wangari talk about national level political and policy debates in Kenya, it also makes me think that a lot of the action is at the county level. Likewise, in India, a lot of the action is at the state level. And I think we do need to be thinking about these arguments about politics in a context of decentralization and what that means for the type of tools that we use. So should we be thinking more about the relationship between political actors, the alignments between decentralized authorities and central authorities, and what are the fiscal tools that are available to central authorities to influence the decision-making of decentralized authorities, particularly where there is a political misalignment, where the decentralized authorities come from a different party or hold a different stance. What can the center do to actually influence them? And whether that's in terms of budgeting tools or conditionalities or matching, do we have the right set of fiscal tools? The other issue that I've heard kind of throughout the presentations is one of fragmentation. And I think we all know, we've all seen these figures that many of us have produced about the extent of the fragmentation of funding at the facility or the provider level. And Sheila's comments on the fact that salaries are excluded from a lot of provider payments, yet creates another funding flow that goes, that's outside, that's not integrated. And I think we should be thinking really hard about strategies to manage that fragmentation, whether it is physically bringing payment streams together or doing an as-if defragmentation, having common payment methods or common payment levels. I think another source of fragmentation that's really come to the fore in these COVID times is the fragmentation of funding streams for public health and for personal care. We certainly see that here in the UK, and then with an added layer of kind of decentralization on top of that. But I think when we worry about how to increase the coherence of financing systems, we also have to think really hard about what is best practice in terms of the integration of funding streams for common goods, as Agnès described them, and for personal care, because in most places those are quite separate. And there's probably, well, there are lots of good reasons for keeping them separate. The same payment mechanisms won't be appropriate for both, but it does create the potential for conflicting incentives when they are kept entirely separate. So I think there's a lifetime's agenda here in terms of interesting questions, but also an opportunity for us as health financing analysts to reflect on whether the tools that we have are the right ones for bringing together this line of technical analysis with political analysis. Over.
Great. Great, thanks, Kara. Some really good, challenging questions. I'm trying to both type and think at the same time, which is a challenge for me. We've got a lot of good questions, and I'm going to now pose some of them to the speakers, trying to give some order to that. And maybe I'll start with Sheila. One of the questions, the 8:19 p.m. question from Kodliev Van Heteren, which is really around this issue, and some people have spoken to it. Given the financial constraints often faced by results-based strategies, these are often cited as the reason to leave salaries out. I mean, I've found actually as well on some of these issues in some countries, using the terminology of today, that the inclusion of salaries is sometimes seen as too politically sensitive, right? And so certainly it does create inefficiencies and disparities, but how would you address the kind of cost of implementation argument at the outset of this type of program, this more output-oriented or results-oriented payment approach? Do you want to jump into that, Sheila?
Yeah, I guess I'm going to build on the theme of my technical opportunities themes, realizing this could be controversial, or since we're talking about politics, this might be internal international development politics.
Controversial is fine, by the way.
There
so
you go. Fine. I mean, my opinion is that all health financing is performance-based or results-based. How would you like to be a minister of health going to the minister of finance saying, oh, I got something new, but you know what? And it's performance and results. And the minister of finance says, well, give me the money back that I gave you for the last 50 years. We need to understand that it's all performance-based. It's along a continuum. It's a gradient of what are, yes, technical provider payment issues. Yet that, it varies by the level of bundling and the directness of incentives. And results-based financing, to me, is just a fee-for-service payment system framed in a different way, making a more direct link to quality improvement. So I would recommend some kind of mixed model, and that it doesn't have to involve that this would be technical under the radar, this mixed model, although of course it will emerge in a political way, hopefully inevitably, particularly related to its connection to pooling. Rather than just separating by the old rigid input-based and RBF, build a mixed model or some kind of pyramid. There can maintain input-based, including for salaries, but to build a core of the middle, which is really the basic core output-based payment system, whether it's a capitated rate or case-based, it doesn't matter. But then if RBF or fee-for-service is put on top of that to target specific things where you want quality improvement and want very direct incentives, then all of a sudden you're leveraging all the money in a more sustainable way. So that's my 2 cents on that. And if I could give a couple of points related to the other question, about in the context of the health purchasing and PFM intersection, I think we need more focus on basic business management. What health professionals or donors maybe haven't been doing right is more focus on business management. We have a lot of disciplines. We have public health, we have clinicians, we have PFM people, we have economists, but sometimes basic business management is a good thing. And to start thinking that service providers aren't just a place where you send inputs, they are a place where services are managed, and that you need a basic management platform of planning and budgeting and spending money and accounting reporting to do that. And then you can add the product or the health services on top. And also governance and management are not the same thing. There's a lot of focus on governance, but very little on management. And a second quick point is to become more cross-sectoral in the work. If we think maybe the health sector has gotten it a little wrong internationally, PFM is good here because it's the same accounting rules and systems for all sectors. That doesn't mean that donors can't have sector-specific investments, but it does mean that multi-sectoral and linking them is important. And this maybe will result in some more of the collective action that Agnes is talking about. And it can maybe really dig into the multi-sectoral questions at the heart of addressing the social determinants of health. So in other words, I think in summary, yes, I think a basic platform, a basic finance and management is going to be helpful to address these questions in the future. And Joe, I wouldn't have any other comments unless you'd ask me another question.
Well, it was just on what you're talking about platforms and managers locally. And this is something I think is coming up more. And maybe just to say a quick word also about the link to local accountability as well and legitimacy, because I think we're one of the problems of just paying things out by inputs. It's really hard to have any meaningful accountability as well for results.
Well, that's right. And here I think if I can jump and say a focus on the difference between the public and private sectors is that I view them as a lot of the same in their financial management and accountability requirements, except for the timing. The accountability of the private sector is not only for financial control and their audits, but it's to produce a product and to receive revenue for it or go out of business. But sometimes in the public sector, when the product isn't clearly defined and it's not well received by the public, then all of a sudden the financial controls or the PFM specialists just take over and drive everything. So what you really need is a balance between accountability to produce the service or deliver services to the population and accountability for financial management control. Both are important. And whenever we ignore one or the other, problems inevitably ensue.
Great. Thanks a lot. I want to turn now to Agnes. There's a couple of questions, I think, part of what Hudliev, one of the ones that Hudliev raised, but also Felix's question around HRH issues. I'm not going to reread them. I think you've looked at them and people can see them in the Q&A windows, but I wanted to ask you to come in on these issues. Agnes?
Yes, well, thanks, Joe.
Sorry, Agnes, there's some background noise on your end as well. I don't know.
Oh, I think it's the ventilator of the computer.
Okay, sorry. Anyway, go ahead. We'll manage. Manage.
Can you live with it?
Evidently, yes.
Yes, on the HRH question, was very interesting. The example of Nigeria. There's a couple of points about it. I mean, one is clearly when we operate in the health sector in a global market. The health sector is globalized, like most sectors now, and it's particularly the case for medical doctors. So if Nigeria, which has a lot of prestigious medical schools, trains doctors who are fit for markets that offer better wages, it is logical that they would leave and migrate. And actually the studies that we've been doing on migration, one of them was actually following a cohort in Ghana, showed that those who migrate are not the poorest of the health workers, right? They are those, usually they are more urban, they tend to belong to families that are wealthier, and they also tend to belong to families where other people migrate. So there is a choice there about life decisions that is made by families, and of course this goes to the broader question of globalization and the freedom of movement, right? As if we talk about equity, there is the big question of, if we think people are equal and should not be discriminated on the basis of gender, race, income, color of skin, or any other, or sexual orientation, we could also ask, why do we discriminate on the basis of where people are born? that in a globalized world, there is a legitimate aspiration of some people to move to markets where they will have better income and better lives. So it's really about choice there. So when it comes to public policies, and you recognize that you actually have universities in Nigeria who actually pride themselves and about the number of people who are able to migrate to the US or to the UK and take those very difficult exams to be able to be certified there and take board exams and other types of certification. So that's a segment of the market. If we're talking about UHC in Nigeria, the question is what kind of skills are needed to deliver healthcare in Nigeria, and what are those services that will be subsidized by the common purse and will be either free or heavily subsidized as part of the overall package of benefits. And that question, the point is that it is rarely associated with the question of what are the skills that are needed for these benefits, and where are we likely to be able to grow these skills for these skills to actually stay in Nigeria and deliver those services. That question is rarely asked. It is partially asked, and when you say that there are new cadres of health workers, it is an answer to that, the community midwives and others for primary health care. But often that conversation is sort of half-baked. There is not at the end the very profound question of, do we really need in 2021 to have the same categories of health workers we had in the early 20th century, like there's doctors and nurses, or can we actually speak about years of training and particular skills? This is all the question of regulation and accreditation, and there is a lot of work on that, and some very solid experience exists, as I mentioned, whether it is in Canada, in the US, in Australia, in Thailand, and including some examples in Nigeria. So that's the question. The other question is always sort of the quandary about public versus private, because a survey was conducted in Nigeria, a service delivery indicator, a joint project with AERC in Kenya, the World Bank and ADB, and as WHO we contribute to this. And it found that in the public sector, the number of visits per health worker is very, very low, right? So it means that there are other things happening there that is actually the way the market works, and the fact that public policies often don't recognize the fact that a very large number of interactions on health services take place in the private sector, and don't really confront this problem in the policy making. There's always the question, okay, what are we going to do in the public sector? And it's unfortunate, if we manage to fix the public sector, somehow the problem will disappear. But there's very little evidence of that. The evidence from high-income countries and even emerging economies is what needs to happen. And it's very consistent with the PFM message, is you need to have a unified system that actually defines who a health worker is and what kind of services they can deliver and how they will be subsidized. And whether the agency or the organization that delivers the services is of public statute or private statute probably doesn't matter that much, because we know also from the autonomy and decentralization literature that an agency that receives public money will naturally follow public incentives, right? And an agency, a hospital that has a public nature, but gets all of its income from user fees, is probably going to act as a market-oriented institution. So to conclude on that is that there is no question that there is not enough health workers, in the sense that we have that massive movement of health workers with countries looking for them. That's a global problem. Now, how at country level this problem is resolved has different legs. It is about, do we train health workers for export? Some countries choose that. There are some private universities in India or in Bosnia and in many other places who actually train health workers to export them. Or do you train health workers to actually deliver services in the country, because it's probably different skills and different policies. I'll stop there.
You're muted, Joe.
Mute. Okay, good. Sorry about that. No, this question that was raised, Cheryl, about which I would oversimplify from Puglieva, talking about, you know, thinking globally and acting locally, and something maybe some of us haven't done enough of. But please go ahead, Cheryl.
Thanks so much for that question, Puglieva. I think it's something we're all grappling with, and this started before the pandemic. I think really this movement, making sure that agendas are set locally, that work is happening locally, and rethinking our role as global partners, decolonizing global health, all of this started, and the pandemic really accelerated it. I think that's a very positive thing, and making us think, what is our role? And we need to all grapple with that. I do think, though, I mean, with all of the conversations that I have with friends and colleagues in all parts of this work, that there is a place for lateral networks of experts and lateral networks of sharing experience, and how we can do a better job of making sure that some of our old divisions and sections of this work are maybe going away, and we're rethinking much more laterally. And I've been very excited about how much the experience that I've been able to bring in from international work into the discussions in New York, and how shocked people are to hear how things are happening, and especially how other countries have handled the pandemic. So I think it's a great time to rethink these roles and how we share experience and build experience as a global community.
Great, Cheryl. Thanks a lot. I was struck when I went to do a little bit of work in California the last couple of years ago, back when travel was happening, just the shock of putting up our data about 44% or so global health expenditure happening in one country was enough to get some attention. All right, Wangari, you're up next.
Thanks, Joe. Just as final comments, and thanking everyone for tuning in, listening to us. I really enjoyed this discussion. I am feeling just a little bit fatigued because I got my vaccine today, but I couldn't miss this chance to just reiterate my teacher, Kara Hansen's comments around equipping ourselves more with public economics and the understanding of the fiscal space. So every time we had this conversation with the head of state or even with the National Treasury around universal health coverage and how we would finance it, the team was very well equipped with health financing lingo, health financing technicalities, the understanding, the reduction of fragmentation, and everything else that we know, but very poorly equipped in the understanding of the larger fiscal space. I think it was really just worth mentioning again, because every time I'd find myself, I don't know what the right word is, almost tight-lipped. So I don't know the answer to the question that they are asking, which is the most important question on whether we go ahead with the program or not. How are we going to pay for this? How are we going to pay for more workers? And just a reminder that the health sector exists in the context of the rest of the country. So if your revenue collecting agency is doing badly, then the financing coming to health will also be poor, because it's poor to roads, and it's poor to education, and it's poor to all the other sectors. So just to remind ourselves, even as we are specialists in our area, every time we're going to have to work local, we do need to know what exists beyond us, and know it to a level that is sufficient enough to make our technical advice that much stronger. Thanks, Joe.
Thanks, Wangari. And that the one point you brought up, which has often been a frustration for me, is the expectation that the health financing community will solve the revenue problem, right? When it is much more of a public finance issue. We just have a minute or so. Kara, there was another question for you. I don't know if you wanted to take that on about the technical and the political and capacities.
Yeah, so it's a great question, Godlieve, and I think the answer is probably no. We have siloed ourselves between the technical audience and the political audience, and I think we need to think really hard about how do we train our, masters in public health and our masters and students to be able to engage with confidence in the act of persuasion and negotiation. And it's a sort of thing that you learn kind of more in a Master's of Public Policy, but you don't learn it in a Master's of Public Health. And I think we should be teaching it, and we should be offering to our graduates the opportunities to gain those skills so that they can do that with confidence.
Great, thanks, Kara. There's just 25 seconds left. I guess I will use that to say one part of the original framing of this session was, whether working for UHC requires us to be political activists. And there's probably many ways to answer it, but it may be about yes, but it might be publicly very visible or below the radar. So let me leave it as that as time runs out. And thanks to everyone for joining. And I don't know if we're done, but the clock is done. So in case we're still on, just to thank everybody and thank the participants and panelists. Or Sinead, are we connected?
Still connected.
We're still connected. Well, good. Everybody who still wants to hear us talk, you can. But just to, again, thank everybody for staying on, staying connected. Good questions, and I think hopefully even better answers. So thanks to everybody. And thanks to the organizers, and thanks to HSR for getting through this very challenging year of the shift to the virtual symposium. And goodbye, everybody.